I'm really pleased to be able to introduce 4 people who are affiliated with stakeholders. You heard about them in the previous panel about the stakeholders. And we have L. Anthony Cirillo, who's a board member of the American College of Emergency Physicians. We have Claire McAndrew, Director of Campaigns and Partnerships at Families USA. We have Molly Smith, Vice President, Coverage and State Issues Forum, the American Hospital Association, and Jeanette Thornton, the Senior Vice President for Products, Employer and Commercial Policy at America's Health Insurance Plans. We'll just begin with each of them making remarks, and we'll start with Jeanette and move down that way.
All right, good morning. Thanks for hanging with us. As was mentioned, my name is Jeanette Thornton. I'm coming here today representing America's health insurance plans, and our members provide health insurance from individual market, small group market, large group market, both the fully insured products and self-insured products, as was mentioned on the earlier panels. From our perspective, we really do view the issue of surprise billing as one of those huge pain points for people in the healthcare system. I think when people share their stories about the bills that they're seeing that are a surprise to them, it really reduces their value and their trust in the viability of a commercial health insurance market. And that's why we think it's so important that we're here talking about today and talking about policy solutions to address it. Today I want to talk about sort of 2 buckets of things. One, I'll share a little bit of our lessons learned from the state perspective, and also talk about sort of where we are in terms of some of the federal policy discussions that are ongoing today. So for a number of years, we've worked with states across the country who have been enacting legislation to address the issue of surprise medical billing. And we've heard from the earlier panelists a little bit about some of the various state approaches. You know, we do already have 17 states that have prohibitions on balance billing, and a number of other states, well over half, that have some sort of protections for out-of-network billing, and that sort of self-insured employer opt-in that was mentioned earlier. But it's so interesting. This issue is certainly a hot issue. I think our state folks let us know that over 40 states have some sort of pending legislation that they're discussing in this area. So certainly something that's hitting state policymakers in their discussions. But I think for a number of reasons that were mentioned earlier, we have sort of pivoted to working at the states to also seeing a need for federal legislation in this area to fill some of the gaps. One of the things that was mentioned was those individuals, about 100 million of people who are covered in the large group market through a self-funded employer. And in most cases, these individuals are not protected by the different state laws that are in place across the country. And it would also be very difficult for an employer who has, a few people in every state across the country to have to follow each one of those state bills for those 2 people. It would just be really burdensome to have to do that. We've also seen a number of states that just haven't acted or have protections that really only address sort of a piece of the problem. And this is, again, something that federal legislation could sort of fill those gaps. And finally, I'll say the issue of ground ambulance and air ambulance is really important to us in terms of addressing, in terms of the stories we've seen around people particularly hit by surprise medical bills. I know that was mentioned, some additional complexities with addressing that, but we definitely think it's important that it's part of the discussion. If we've solved it for hospital or physician services, but not for ambulances, I don't think we've really solved the problem. So definitely something I think it's really important to stress in any of these discussions. The last thing I'll mention, and I think Lauren mentioned this in his opening remarks, that it's important that consumers are taken out of the middle of the issue, but also it's important that any solution does not increase healthcare costs. So we have to look at how this impacts consumers' pocketbooks, both in their out-of-pocket expenses, but also in how it drives health insurance premiums across the country. So it's important to keep that premium component in mind. So let me shift a little bit to some of our policy recommendations, and we welcome some more discussion throughout the panel. I think all of us here on the panel would agree that we support legislation that would sort of take people out of the middle of this discussion, sort of the ban balance billing, get consumers out of the middle, have consumers be responsible for a cost-sharing amount that's more aligned with what they would be expected to pay if the care was in-network. I think we can all agree on that. But one of the challenges I see, if we only do that, if we only ban balance billing, if we only look at the cost-sharing amount, we're not really solving the problem. I think Lauren showed this in some of his data, that in some particular provider types, the market is really, I'll use a complicated economic term, it's out of whack. right? We see these extremely high payments on one side, and if we're just basically saying, okay, health plan, you work this out, we're not solving the problem. I think it's going to lead to higher health insurance premiums. And that is why we're really interested in looking at these different sort of benchmark-like approaches. We've seen a number of states take a look at those and enact legislation, and I definitely think that has to be part of the solution. So it has to be something that doesn't raise healthcare costs, but is also fair and transparent for the providers. Obviously, this is something that, takes two to tango here. We want to make sure they're addressed. I want to also respond to sort of the comment that, if you set a benchmark for these narrow surprise billing situations, this is a slippery slope to government control of healthcare. I really disagree with that premise. Just yesterday, the AEI, I think your neighbors just right up the street, put out a paper that looked at the issue of surprise billing and also sort of recommended similar type of solutions for some of these narrow situations, also highlighting some of the high costs. So this certainly is a bipartisan issue if you have Brookings and AEI on different sides of the political spectrum, all sort of raising these issues and potential policy solutions. So super fascinating there. I'll talk briefly about arbitration. We certainly have seen the use of arbitration to sort of resolve these disputes between providers and health plans in a number of states. The one thing I'll say about that is it can be rather clunky and it can be rather expensive. We pulled some data from some arbitration firms that are out there and used in Texas and some other places. Just a filing fee of $1,500. So if you're talking about some of these small things that can really add up when you're talking about millions of claims and different areas and how that could potentially add administrative costs to a system that I don't think we all need right now. I also want to hit on the issue of consumer notice. A lot of individuals are focusing on, well, if we just had transparency, if we just had a notice around what providers and what networks they're in, that would sort of solve the problem. If you're going into labor and you get that stack of paper, you'll sort of sign anything because you're going through a very challenging time at the moment, right? You'll sign anything. And so just allowing consumers to get notice, by the way, you may see an out-of-network provider, you may be balance billed, you're going to sign it, right? And that's not really solving the problem. It's certainly giving people notice, but again, it can't just be part of the solution. Now, whether or not notices play a part of that is something we can certainly discuss. So just sort of in sum, it's really important that as we're looking at surprise billing, we think about the pricing and the high prices that are out there, and we think about solutions that both address consumer protections, which I think we will all agree on, but also look at ways to sort of correct some of these market distortions that we're seeing in the market, and also making sure that we don't increase healthcare costs. I don't think this is an issue of narrow networks and high deductibles. We see this across the spectrum. I think this is an issue that we're really excited that folks are talking about, and we're hopeful to see some action and discussions this year on this issue. So with that, I'll turn it over to our next speaker.
Thank you very much. And actually, before Molly Smith speaks, if I was putting this panel together 2 years ago, I would have had an insurer, a physician, a consumer. But it's really what I've been learning since shows the very important role that hospitals play. So I'm delighted that we have you, and look forward to your remarks.
Great, thank you so much, and good morning, everyone. Thank you for having me here. So this is a really important issue for hospitals, absolutely. We care a lot about the patients that we serve, and it is not a good scenario. I think we, again, all agree if they receive bills that they were unprepared for, that they weren't expecting. Our work on this issue actually goes back several years. The focus of Brookings' paper has been on, or is on state-level solutions, and in fact, that's where we really began our work. We worked very closely in the development of the NAIC's Model Network Adequacy Act and the surprise billing provisions therein. And when that act was completed, we adopted it or endorsed it, and we worked with our state hospital association colleagues as they were working with state policymakers to identify solutions to surprise billing. Unfortunately, though, for many of the reasons that have been mentioned here already, it's become clearer what some of the limitations are on state-level solutions. So the ERISA preemption is one, obviously, oft-cited, but one that Jeanette just mentioned, which is very important to us, is the fact that we don't have all of the states moving towards adoption of resolution. We obviously have a ton of activity, but we're not optimistic at this point that all patients across the nation would be protected if we rely on the state process. So we have now really shifted our focus to federal solutions, and we do support federal legislation to address this issue. I will say with respect to hospitals, I think what we've heard a lot about today is that it's a pretty rare instance where it's the facility or the hospital sending a balance bill. Not to say that it doesn't occur, but it is a more sort of rare instance. What often happens, it's not rare though that of course there's out-of-network hospital care, particularly in emergency situations, but it's that health plans and hospitals have sort of forever dealt with that problem, and they have a long-standing history of sort of negotiating out-of-network emergency reimbursement. Obviously, as we mentioned, disputes do occur, balance billing can occur, and as we're looking towards a solution, our first principle is that patients should not receive balance bills in scenarios like emergency care or when they go to an in-network facility with every expectation that their providers are in-network and receive a bill from an out-of-network ancillary provider. We do want them to be taken out of the middle. We do want a prohibition on balance billing. But once that happens, we do get to this question about what is the role of the government, whether it's the state, if we're still talking state solutions, or the federal government, in getting involved in setting the reimbursement between a provider and the plan. And as I mentioned today, on the facility side, this process is largely working, and it's not clear to us that the government has a need to sort of intervene in that process, whether it's by setting a rate or some sort of arbitration process. We think that, at least for the facility portion, that can largely be handled the way it is today. Speaking a little bit to the issue of setting rates, I think there has been a sort of general assumption in some of the comments that we've heard this morning that hospitals can either absorb the additional cost of kind of subsidies to physicians in order to prevent balance billing from certain specialties from happening, or that they can simply pass those costs on to the insurer. If we're talking about the latter situation, I'm not really sure what we've gained if we're simply then having the insurers paying the hospitals more. It seems that we've just sort of disrupted a process to the same outcome. And if you're talking about the former, I think there's a gross misunderstanding of hospitals' ability to absorb these additional costs without some sort of ramifications for other investments that they might make, whether it's in the services they provide to their community or other activities. So I think we should be cautious about assuming that hospitals can just automatically sort of take on those additional costs. Jeanette raised the issue of notice, and I think that this sort of fits into a broader discussion around patient education and patient navigation. I couldn't agree with you more that I don't think notice is, first of all, it's definitely not a comprehensive solution. It's not clear to me how much value it adds at all anyway. Not to say that patients shouldn't have a good sense of who's delivering their care and whether they're in network or not. But again, from our perspective, if you protect that patient from a balance bill, it somewhat becomes irrelevant. And we've just heard a lot of challenges with explaining to patients and adding to their confusion at a very vulnerable point in time. But that's not to say that we don't all play a role in helping patients navigate the healthcare system. Our members, of course, every day are working very closely with the patients who they serve to help them coordinate their care, to navigate the healthcare system. We work with their insurers to help address issues or questions around cost and cost sharing. And I think that there's definitely more that can be done there. Employers, when they're selecting products on behalf of their employees, helping them better understand their coverage. Same with making sure that provider directories are accurate. And then this work actually extends beyond just our members and doing their parts. We actually, as associations, have worked together on consumer education tools. And just this last fall, actually, AHIP, the AHA, and I see HFMA here in the audience as well, worked together to develop a consumer guide to help educate patients about what surprise bills are, why they occur, and how to avoid them. So that's work that we're deeply committed to, and to work with our stakeholder partners as well as our members. The last thing I want to note is the issue of network adequacy. And I thought the paper had some interesting data that suggested that this isn't an issue of network adequacy, and that the incidence of the potential for surprise bills can occur in narrow network plans or broader network plans. But we are hearing about an issue that related to networks that I think is worthy of further exploration. And that has to do with a misalignment between the providers that are in network and the facilities that are in network. So you may have a network that's narrow or broader, but you have the issue of the anesthesiologists, for instance, that are in that network don't participate or don't practice at the facilities that are in network. And it's something that we're increasingly hearing about. We ourselves don't have data at this point, but I just encourage you to think about that as this sort of broader issue of network adequacy. The final thing I just want to mention, and this was raised, I think Mary mentioned it in her comments earlier about some of the other sort of tangential issues that arise. I think this one is worthy of note. So our members do get a lot of calls from patients who are confused or concerned or surprised about their bills. But in the vast majority of instances, the bills that they're calling about aren't what we're talking about in terms of a surprise bill. They are surprised by their bill, but it's simply because they are unfamiliar with their insurance design and particularly their deductible. And so they call very surprised that they maybe have a $2,000 bill, but they thought they were covered. I know that is not what we're talking about today, and this is a very different issue, but I think it's worthwhile in noting that that is, again, the vast majority of calls that our members receive about surprise with bills, and that's not going to be addressed through the work that we're doing here. It is, though, why the AHA has consistently supported and advocates for enrollment in comprehensive coverage with comprehensive networks so that issues like that are minimized. So just wanted to raise that, and thank you again this morning. Really looking forward to the discussion.
Thank you very much. Dr. Cirillo?
Well, good morning, everyone. I was going to say thank you for inviting me, but I'm not really sure I want to do that. And, in policy and advocacy, the adage is that you're either have a seat at the table or you're on the menu. Somehow I feel both all of a sudden. So I'm a practicing emergency physician. I will be working a shift tomorrow morning at 7 o'clock. And I want to share with you that of all the stakeholders here, and I appreciate the role that each of us play, but I'm going to be at the bedside tomorrow with another person who's entrusting me to take care of them. And I would just have you all stop for a minute and think about some of the portrayal of physicians. And I'm here on behalf of the emergency physicians, but I'm the only physician here. So I just want you to remember that none of us went in this to gouge people, to ransom patients. Look, I went into medicine to take care of people, and I truly believe that. Look, there's an issue that affects your constituents, the people I take care of, and they tell me the stories. Look, if they get a bill from somebody that's out of network, I understand that that's a problem. They tell it, you'd be surprised at what people who come to the emergency room will tell you, even though I just met them. They tell you a lot of stuff. And they share their stories about how an out-of-network bill might have financially hurt them. They talk about high deductibles. They talk about the system is so complicated that they can't possibly figure out what they're going to owe, even when they ask all the right questions. So I think, honestly, for all of us who care about this, there is an opportunity for all of us to work together to make this better for you, for your family member who goes and gets a procedure. And I will share with you a personal story, and I couldn't have made this up. My 24-year-old son, who, thanks ACA, is still on my health care insurance, had a colonoscopy yesterday. And when he was having problems, and he lives in Boston, we live in Rhode Island, but he went to his PCP, had some initial testing, and the recommendation was you need a colonoscopy. And now I'm a parent. Now I'm just concerned. And so he goes through the colonoscopy yesterday. He describes how wonderful the prep is, if anybody of you have ever had that. And then he calls me to say everything was okay. And all you feel is a sense of relief. It was about 2 hours later I said, hey, by the way, was the gastroenterologist in network or out of network? And his answer was, I don't know. And I'm like, so here I am getting ready for the panel, and I'm like, I'm the know-it-all guy here, right? And then my son didn't ask the right question. So look, if that level of complexity didn't get to him, we have work to do. I want to speak to the issue of this, the market being broken. And I just want to share with you some of the reality of emergency physicians and what we do. So every day, 15% of the people who I take care of are still uninsured. 30% of the people I take care of have Medicare, 25% have Medicaid, and 30% have commercial insurance. For the folks who have no money, who are uninsured, we collect essentially zero. For folks who have Medicaid, we collect about half of Medicare, maybe $75 to $80 on average, regardless of how sick they are. And when people start referencing numbers of the market's broken, you have to, and you want to compare to other providers. Look, an office-based provider, they choose the patients they want to see. Lauren's right with an O. There is inelastic demand. Every day, the patients who feel they need to come, and under EMTALA and under prudent layperson, they should come. When those patients come, I take care of them. I don't ask them about their insurance. I don't challenge them about whether they can pay. Not only is it legal, it's immoral, and I would never do that. But we take care of who comes. And at nighttime, particularly in a rural hospital, if no patients come to a rural ED overnight, but the physician is there and ready, who covers that cost? So there is a cost to having an emergency care system, that's the safety net, where somebody's there 24/7, 365, and we take care of people regardless of their ability to pay. Look, that may not be a fair system the way it was set up, but it's the way the system is. So I will offer to you that when people start talking about, that there's gouging or there's bad behavior, look, the system that we create legislatively, first of all, should fix it for everybody, both at the state level and at the federal level. It should fix all of the problems, not just a certain group of providers, not just at in-network facilities and out-of-network providers, but it should really fix this for everyone. And I will offer to you the only solution that does that right now is arbitration. And rather than conjecture about what could happen, I think we should be scientific about this and look at the history of what's happened. And New York State has the model that has now 4 years of a track record. And I will offer to you that the solutions there have been successful. And you know why? Because when was the last time you heard a story in the media about an out-of-network bill in New York State? I challenge you to find one. The system of arbitration with reference points has worked. Charges have not gone up, and for the 5 levels of emergency medicine, some of the charges have actually started to come down over 4 years. The number of cases of arbitration eligible in New York State in 2018 was 552. That's out of 3.2 million commercial ED visits, not the 8 million total visits, but of 3.2 million visits with patients with commercial insurance, which is about 40% of the New York State market, 552 cases of arbitration, and the decisions were split about 50-50, which to me means that the system is working to do what we really want, which is to get plans and providers to be able to come back to the table and negotiate an in-network contract that they can live with. We think that New York State has worked to do that. It's taken patients out of the middle. It's created, for an analogy, if you're a bad bowler, you pull up the bumper guards so that you can kind of bowl in those bumper guards. And as long as you charge and pay within the bumper guards, you're going to be okay. And the patient's out of the middle. And for my company, I will tell you, I work for a company that's a larger national company. But in New York State, before that law went into place, we were only able to negotiate a network with 5 of the 8 larger insurers. Once that system went in place, we're now in network with 7 of 8. So we were able to make progress and get back to the table with an insurer and come to something that we really believe works. So from the provider community, I will tell you, we do care about patients. We're not really trying to take their money for no reason. And that there's a system, I think, of all the problems in healthcare that are really, really, really complicated, this one's fixable. And I think if we all work together as stakeholders, we can do that. So thank you.
Thank you. Claire.
Well, hi, everyone. Thanks so much. I'm Claire McAndrew with Families USA. Families USA is a consumer advocacy organization, and we're focused on making sure that everyone has access to the best health and the best health care, regardless of who they are or where they live. So obviously, surprise out-of-network bills are really an affront to our mission. And while we focus our work primarily through policy advocacy, both at the national and the state level, by nature of the information we put out there, what we're talking about in the media, on our website, we get a lot of calls from the consumers who are facing surprise medical bills. And so we hear a lot about just how big of a problem this is. And we've been hearing about it since the 90s, when with the rise of managed care, more and more consumers were confronting this issue. And since that time, we've been focused state by state, year by year, on putting protections in place with policymakers and stakeholders. And so I really agree with what we've been hearing all day, which is that those protections at the state level have been really meaningful, really important, but they're patchwork. They obviously leave out self-insured folks. Some states are trying to bring in the self-insured market through an opt-in, but it's not really addressing that problem. The solutions at the state level are obviously slow. They're building momentum, but to really get everyone covered across the country, we really believe a federal solution is needed. So it's a really exciting time. We see a lot of opportunity. And we have two principles that I think echo a lot of what we've heard about all day for that federal solution. The first, of course, is protecting the consumer from the balance bill itself. And the second is holding down underlying costs. And so regarding our recommendations for how to achieve those principles, the first thing I want to talk about is the scope of the protection. I really agree with what we heard from Commissioner Altman in Pennsylvania about making sure that the scope is broad enough to include all situations where consumers are getting surprise bills. We worry that if we try to list off which providers are included in surprise bill protections, we are inevitably going to leave out situations where consumers are getting surprise bills. Because consumers don't just get surprise bills in facilities, they don't just get surprise bills in in-network facilities. And I think that Commissioner Altman's example about the mammograms, where consumers were going to in-network OBGYNs that they've been going to for years, and then all of a sudden those OBGYNs were sending out mammograms to be read by out-of-network labs. That's a surprise bill that consumers deserve protection from, so we're urging policymakers to really think of that full scope in legislation. We also want to be sure that the bills are just never reaching the consumer. We heard earlier from Lauren with an A. I'm going to change that up and call her Lauren B, because Lauren Adler told me he's confused since his last name starts with an A. So Lauren B talked about the fact that when consumers have to take action to get protection, it doesn't happen. They don't know how to get that protection. So we really want to ensure that to the greatest extent possible, consumers don't actually have to do anything to get protection. They just don't get the surprise out-of-network bill. And along with that, that has to mean that consumers in a surprise bill situation are only charged the in-network rate for care, and that legislation is explicitly clear that the costs also accrue to the in-network deductible and the in-network out-of-pocket cap. I think the legislation has to be crystal clear about that so there's no debate. Notices have come up a lot in this discussion, and I think that actually relates to the scope discussion. There's some situations where clearly we just wouldn't need a notice, and I think that relates to emergency care or in-network facilities. But going back to that dialogue about the scope of providers, there's some situations that maybe you wouldn't typically think of receiving a surprise bill where consumers are getting them, and I think that relates to those typical doctor's offices. I recently got what I consider a surprise bill. I'd been going to the same dentist forever, and then one day I got there and they were no longer in my network. My plan didn't tell me, my dentist didn't tell me. I really would have liked notice, and without that notice, I don't think that the plan should have been able to, or the provider should have been able to balance bill me. So maybe we're not considering that a surprise bill in this dialogue, but I think it should be considered one. So to discuss the situation about underlying costs, this is a really interesting issue, or it's been interesting from the consumer perspective. I've actually been told by a stakeholder that I shouldn't care about the billing rate between the insurer and the provider, because as long as the consumer is protected from actually getting that bill, like that the consumer issue is solved. And that's frankly not true. If the rate between the insurer and the provider is not reasonable and not holding costs down, that is a consumer problem. Consumers will see that in their premiums, and they will see an impact on the network structure. And so Families USA does have some perspectives on addressing this problem. I will say that we think it can be addressed in different ways, as long as the guardrails in the framework are set up correctly. And so the discussion earlier today from Lauren Adler started with a discussion of different ways to address this, including a benchmark rate. We think a benchmark rate could be a great way to go if that rate is set appropriately. We've been supportive of state bills that were set with 125% of Medicare as the rate. We also think that arbitration is worth exploring, again, if it has appropriate guardrails. Additionally, I think the ideas of trying to make sure that a facility has the same network status as all of the providers who practice there is a great idea. I do have questions about politically if we can get that through in a timely manner. And another thing I would throw out there is, does it have to be either or? I've heard all of the sort of concerns about each method: arbitration, administratively burdensome, is it costly, could we get to the appropriate benchmark rate? Could there be a combination where sort of low-level bills are set with a benchmark rate, and then the more high-cost bills are set at arbitration, and they are compiled together, so there's no administrative cost for each and every time you go through arbitration? I guess my message overall is that I think this is a solvable problem, and my biggest concern is that stakeholders are going to fight over these details to a point where we miss the opportunity to pass legislation, and that would be the biggest disservice and frankly a harm to consumers. And so my plea to stakeholders is make a good faith effort, come to the table and get this done, because this window for consumers to make change is critical, and consumers cannot wait any longer for protection. The last thing I will say is that although I think a federal solution is what's most needed now, I don't want to discount the activity at the states. I think it needs to keep going while we move forward on federal legislation, and even potentially after, as states can continue to innovate above and beyond what we see at the federal level. We are open to the idea that a state that's already solved this problem in a way that works for its market with rigorous standards could potentially keep that protection in a way that allows them to not be preempted by a federal standard. But I think you're hearing my message loud and clear. It's that stakeholders need to come to the table at a good faith effort now to work this out, not let payment rates be something that keeps legislation from passing this year. It needs to get done, and Families USA is really eager to work with everyone to make that happen. So thank you.
Well, I'd like to thank all of you for very thoughtful comments. And one issue that kept coming up today from Claire and the earlier panel is the situation about balanced surprise bills in beyond the situations that we're all focused on: ambulances, hospital-based physicians, et cetera. And the question is, on the one hand, I don't think we want to apply these approaches to all physician services or all provider services, because that would be a radical change I don't think could get done. So the question is there anything that can be done in these little pockets? Or is it something we just have to say, well, we solved 95% of the problem? I don't know if anyone has any thoughts on that.
Well, I can start. I mean, obviously, I think our most pressing issues are sort of emergency care, what we call sort of unintentional care. So if you're at an in-network facility and you're seen by an out-of-network provider, and then the ambulance issue that I mentioned. Some of these other scenarios, I think we need to think about consumer simplicity. We worked together on this consumer guide for surprise billing, as Molly mentioned, and I think it was like 70 pages. So if you need a 70-page document to help people avoid surprise bills, you have a problem, right? And so I think where we can focus on in those other scenarios are some of these transparency tools, so that there's an education with providers that they're educating their patients before that mammogram is delivered, or before, this is the radiologist I'm going to use. Let's work together to make sure that that's an in-network. There's other sort of tools that could be available. So I think I'm more in sort of, let's start small and look at where we can really have some meaningful action, but think about other solutions that could address some of the other scenarios that have been mentioned.
I think, Paul, in critical situations, if you have one person who's responsible for a critical activity and that person doesn't do that right, then there's a failure. So I think there are multiple, there's a responsibility of the plans, of the facilities, of the providers and the patient. And I think if we all align on that and we have a system of checks and balances where each of us is asking that question, hey, is this going to be an in-network or out-of-network service? If we all take responsibility for that, I think we have a much greater chance of eliminating those situations where care is anticipated, it's scheduled. All of those we really can fix. I think that's the easy one here, because that's one that has nothing to do with payment. It has to do with just the consumer, the patient, being able to make a really informed decision.
So I guess I'll just say that, to me, transparency doesn't address consumer issues unless it's transparency with a stick, whereas if consumers weren't given appropriate advanced information in advance, they don't have to pay for care, for example, out of network. So I gave my example of my own situation. I wasn't given advance notice. There was no transparency, so I don't think I should have had to pay for an out-of-network service. And there are some state laws that I think are doing a better job of getting at some of the issues I mentioned. For example, In New Jersey, it's very clear that if an in-network provider uses the services of an out-of-network provider or facility, such as an out-of-network lab to read results, that surprise billing protection is applicable. And so, I will say that you could probably tell by my remarks, my perspective on this as someone in the sort of working from an advocacy angle is to get something done without falling on the sword over issues as long as we get to maybe 95%. At the same time, I think it is short-sighted to try to assert that surprise bills happen mostly, or only in these certain facilities, when really we're hearing from commissioners that they're getting massive complaints about things like in-network providers in a doctor's office setting, not a facility, sending labs out of network. And so I don't think we should see this as sort of a construct that applies in a certain setting and policy must address it that way. I think we should be moving towards trying to address it in, frankly, all care settings.
I have another question, and then we'll go to the audience. The growth of staffing companies, particularly in some of these specialties in recent years, has that been a positive or a negative for the issues of surprise billing?
Well, let me just start. Maybe I'm going to start not by answering specifically about surprise billing, but I will say that there are some places in the United States, particularly in rural areas, where hospitals have a very hard time recruiting for key critical staff. And in those instances, it has been very positive. And it's not just rural areas, but that's, I think, the prime example, where it has been very positive to have partners who are able to bring that expertise into an area that otherwise can't recruit for it. So, your question is very specific, but I would encourage us to think more broadly about the pros and cons of these kinds of constructs beyond just that.
If I may, I think that we have seen some data. I think the Zach Cooper analysis that was cited in the Brookings report does sort of show the impact when you have consolidation and certain staffing companies coming into a particular region and what that does for healthcare prices, and also how it does potentially drive up the rate of certain billed services. So I certainly think when, sort of money, sort of the question earlier about there's a loophole out there, sort of money is sort of following the loophole. And a lot of times this is happening in states that have very specific surprise billing type laws. Texas, for example, where there is reference to billed charges. And so the companies are sort of following those protections. And I think that's why our member plans in Texas are really actively advocating for some changes to the Texas law. And we've sort of seen some of the ramifications of that in that state.
I would just say that there's been consolidation in many aspects of the healthcare market, on the facility hospital side, on the insurance side, and to some degree on the provider side. I don't know that that's a good or bad thing. I think that really is dependent upon how those individual companies and entities operate. And in Zach Cooper's work, Zach looked at one insurance company and he looked at two provider companies. I don't know that that's a valid sampling of the entire market. And I would say if we're going to really make judgments about either side, we should really look at the whole market. The company I work for, 95% of the patients we see are in network. So not every company takes the same approach. Not every insurer takes the same approach. And I think it's about how does that local market, and then I would say the rural hospital in Montana, might use a contract group like ours, or they might contract with a small group of providers who want to stay in rural Montana. The contracting dynamics in that situation are so different that doing a one-size-fits-all approach really is not fair to either side. And I think that's the unintended consequence, is you do have markets where the system works, the providers work with the plans, and really this is okay. It's not perfect in every place, but I think we have to be careful about generalizing about whether consolidation is good or bad, because it really depends upon that market.
Thank you. I'd love to have questions from the audience.
Real quick, on the scope of providers, one thing that strikes me as an issue, it sort of relates to the notice question, because there's a sense that if for good reason the principal provider and the patient want to go out of network, they should be allowed to. And so to the extent you cover all situations of out-of-network billing, you've got to provide a way to opt into that. But if you do that, then you've got to decide, do we hand this piece of paper to everybody who goes out of network or only to select groups? And so I'm just wondering if there's any solutions to that problem, or if one reason to stay more restricted is to not have to deal with the opt-in problem.
I mean, I would say this. I think a lot of states have sort of grappled with this, sort of in what type of scenarios do the state laws sort of apply. And so I think we can learn a lot from the states. I think that the challenge here is these are often providers, and I think Lauren mentioned this, where you don't say, oh, I want a great anesthesiologist today, right? You're not necessarily making a choice. You're not searching a provider directory for these providers, and I think that's why we've seen some of these distortions. But I think there would be some operational challenges in terms of how do you make sure that the provider and all the parties involved sort of understand, is this protected by this surprise bill legislation, or is this outside of the scope? And I think that gets into really some technical operational issues that we'd really have to think very carefully about as we're implementing and designing it.
Yeah, and I agree there's certainly challenges to making this a streamlined effort that's not an extreme paperwork burden. Mm-hmm. There are laws, I think even in the District of Columbia and beyond, where there are requirements that practices have to provide good faith notice, if you're going to be leaving a network, or issuers have to provide notice if there's contract termination within 30 days or 60 days. And so there's also sort of that element of, if you are terminating contracts, how do you notify patients of the change? And if that notice doesn't get out there, is there a period under which there's some responsibility for in-network payment? But to the question of more broadly, do you need to have some sort of understanding transparently to the patient to sort of sign on the dotted line that this does not accept my insurance? I think that's an open question, and I don't know that I would rule it out at this point. But I think this is an area for future policy making to make sure that there is transparency there.
Yeah, the gentleman in the dark sweater.
Hi, thank you so much for your statements today. Two scenarios I like to...
Could you identify yourself, please?
Yes, my name is Steve Chaz.
Okay.
Okay, hi. Two scenarios. The first one is at a recent hospital stay, I did my due diligence. I identified that the surgeon was in network and even spoke to their office and asked them to make sure the anesthesiologist was in network and that the facility was in network. But during the arc of that hospital stay, I had a parade of white coats come to see me at the bedside who were on the teams of, let's say, the surgeon, either hospitalists or other anesthesiologists coming in to see me and would eventually charge me. Their visits with me would sometimes be at the doorway. Hey, how are you? And they'd walk on, and that's a $475 charge. Someone else would come and say, just checking to see you're all right. I'd say, I am, and they'd walk on, another charge for that. So there is an intersection between surprise billing and unethical billing that hasn't really come up. And this is something I've observed on 2 or 3 recent, sadly, experiences at hospitals. That's scenario 1. Scenario 2 is even doing the due diligence of investigating doctors in directories or practitioners in directories, whatever they may be. Just because they're in the directory doesn't mean you'll be covered for them. And even after multiple phone calls to the doctor's office or practitioner's office, as well as to the insurance company, I later found out that unless they're insured at a particular address, that if you see them in their other office where they say, well, he's not free at that office, but at this office, 10 blocks away, he can see you, that all of a sudden he's out of network or she's out of network. Please address these overwhelming burdens to consumer and how to navigate that successfully.
I can start with the provider directory one, if that makes the most sense for me as from a health plan. So yes, I think that the importance of accurate, reliable information in a health plan provider directory is really important. I would say that our plans are working hard to try to get the best, most accurate, up-to-date data possible, but I do know sometimes there are gaps and challenges with that. We also rely on the practitioners responding and letting us know when they move and when they change. So it certainly is a two-way street in terms of ensuring that the provider directories are accurate, but I definitely agree that that's certainly welcome discussion on how do we improve the accuracy of those directories. I don't know, Molly, do you want to talk about the other one? I thought you would.
Yeah, absolutely. So I think what you're really referring to are consulting physicians physicians who come by. And, you know, again, I think that in our definition of when a surprise medical bill could occur, that fits the bill. So when we say that we do not believe that a patient should be balance billed beyond their network cost sharing, it would include the scenario that you just described. Now, I can't really speak to that sort of physician, and maybe you're an emergency physician, these aren't emergency physicians who are stopping by, so I don't know to what extent you may want to comment. We don't have sort of those physician specialties represented here to sort of explain that process or what's happening, but just from our perspective, from the facility perspective, we would like to protect patients in those situations.
Thanks. Gentleman in the white hair.
It could be worse.
Hey, I've got some, right?
It could be worse. Yeah, there you go.
My name is John Hennessy. I work with a firm. We help health plans and patients with these high balance bills. I think you're correct. It's a rare incidence, but when it's your bill, it's a really big deal. Sometimes in healthcare we get very caught up in we're special, we're different, but in our view, a lot of what we see are basically open price term contracts, which are dealt with in the Uniform Commercial Code, that the purchaser, in the case where there's not a pre-agreed price, is due a reasonable price. And so one of the things we do is work on that. The challenge is, how do you get to prompt resolution, rapid dispute resolution? And we appreciate that there's some support for arbitration. We get that it's difficult. But if we're not doing arbitration, how do we get to prompt dispute resolution so people aren't sitting with these house bills, because some of them are that big, for 6, 8, 12, 19 months and worried about their credit? So we like arbitration, but we're interested in what other models get us to an answer quickly, because I think that's probably the most important thing, is so people can move on. I think it's incredibly difficult to be a decent healthcare consumer. It's tough to figure out what TV you're going to buy at Best Buy when you see a wall of TVs. In healthcare, it's even tougher. So any thoughts on, if arbitration isn't the right answer, what is something that gets us to yes or no as fast as we can?
So I would just point out that in New York State, it has a 30-day process. And it's done by document submission. So it is not your traditional arbitration process where people go through a long process and go in person. So basically what happens is a claim is filed. The New York State Department of Finance issues an IDR number to that if the claim is deemed to be eligible, and many of them are not eligible because they're not really an out-of-network situation. Documents are submitted by both sides, and the arbiters review those, and a decision is made within 30 days. So it's not the traditional arbitration process, and so we think, again, that there's a lot about what New York State has done that I'm not sure they realized how forward-thinking they were and how many questions they were answering, but we think they've set up a good process that has worked to really take the patient out of the middle. It's not cumbersome. It's not overbearing. We got verbal, and I know verbal doesn't count to anything in the world, but from New York State, one of the deputy commissioners, that there was no additional administrative cost, that they assign this to people within their division. The cases get assigned to the arbiters, and the cases get ruled. And so we think there's a lot to look at there. No answer is perfect, but we think there's a lot about that system because it covers all of the providers. It covers all of those scenarios. We think that they may have really found a sweet spot there.
One of the good sort of lessons that we can look at is under the Affordable Care Act, there's something called the greatest of three rule. And so for emergency room care, it does provide some sort of payment benchmark in which plans have to follow when there is an out-of-network emergency that a consumer faces. And what this does is it does allow us to pay the claim to the consumer very quickly and have a good understanding from a rate setting and actuarial perspective what those costs are going to be, and be able to automate that in the claims process, so we're not sort of kicking it out of the automated process to look at some of this more manual process around arbitration. That's something that's been in the market since 2014. It's a good sort of something to look at as we're thinking about this.
Yeah, so I think to sort of maybe summarize these two comments with arbitration, and that's, we mentioned that we're open to multiple models. Arbitration, from our perspective, could work with the right guardrails, and one of those guardrails would be timeliness. So to your point around arbitration, it actually takes longer than some of the other options on the table because you have to go through a process, and that's I think what Jeanette is referring to. So from our perspective at Families, if you were going to have an arbitration process, we'd want to make sure it was time limited and that it is binding. So there's no going back and revisiting it. But to Jeanette's point, if you had a benchmark rate saying this is the rate we use in these situations, that rate is what is used to pay the insurer to the provider. We've mentioned 125% of Medicare as an example. You don't even have to go through a negotiation. It's just, this is the rate, it's paid, and that can happen even faster. And so we're open to both if done right, but I think that's to address sort of that question about timeliness.
Could I just, though I'll be very quick, just about some of the comments about the New York model. So as I mentioned before, very rarely do facilities and health plans get into these sort of protracted disputes. So they have not had to really rely on the New York arbitration model. It's really rather been the physicians. However, we have heard very positive things from our members in New York State in particular. Again, they're not necessarily going through the process, but the doctors who may be working in their facilities who do go through the process, or even more so, what's more frequent, it just sort of avoids the need. It really creates an incentive for the physicians and the plans to work it out before it even gets there. So I will just say, just to underscore the comments that he made, that has also been the experience of hospitals in New York.
And the New York State Health Foundation issued a report at the end of February about, hey, where are we? Is the process working? And they reviewed their system, and they give themselves a fairly favorable report on the process. The two areas that they said that they wanted to work more on were network adequacy and transparency. So I would tell you, I think that's a good report if you want to get a sense of where New York State feels they are and how the process has worked for patients.
Okay, we have time for one more question. Yes, sir.
Just quickly on the dispute, we've heard a lot of talk about these dispute resolution processes like arbitration, but I think you have to take a step back a second, and you'll probably know this having dealt with your dentist. For a consumer to call the billing office of a hospital, or to call their insurance company, or to call their doctor's billing facility, it is an incredibly difficult experience. There's typically a lot of finger pointing. The doctor says you have to talk to this one, the hospital says you have to talk to that one. Nobody seems to be saying, if you're unhappy about this, other than you can write a letter, here's what you can do. And so consumers are left not having any idea how to navigate this. Their insurance company will tell them, well, this is the contract rate, or under your plan, this is how it works. You have to pay the balance bill, period. And then, of course, call centers are set up so that you can't get to a business person or a higher level person. So you've got these barriers to utilizing things like arbitration that are not, arbitration is not going to be effective if people are not able to navigate the system easily.
So I could not agree with you more, and we've definitely seen different approaches to dispute resolution, one that has to be patient-initiated, and other where if you ban balance billing, it's really the provider who initiates the process. The patient may be completely unaware at that point that there's even a kind of a behind-the-scenes negotiation happening because they've been protected. We think it's really important that you look at the latter rather than the former. Because I think we've seen in Texas, for instance, now I think there's a lot more awareness among consumers now that process exists. But when they have to initiate, there's a long lead time where you may have patients who are paying bills that they actually don't need to pay that could go into the process. So I think that I completely hear your concern, but this is a design feature that has been solved for and can be solved for if we implement something like that at the federal level.
Right. Like the point is, those bills don't come to you anymore. Right. Like the bills are banned. So you're only now getting, in these situations, you, the consumer, only gets the bill for the in-network cost, and it's happening behind the scenes that the insurer and the provider work it out.
But it does apply to this gentleman was talking about fly-by.
No, in the future, if we pass this legislation, he no longer gets those. He no longer gets those bills.
I can't fix the flyby part.
I think
Okay, yeah, let's.
Oh, sorry.
I think this is, we've run out of time, and I want to thank the panel for a marvelous job, and thank the Brookings staff for making this conference possible, and the Laura and John Arnold Foundation for their support of our surprise billing project.
And
thank you very much.
Thank you.
Thank you.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.